Hello, everybody. Welcome to 90 minutes of knowledge sharing. My name is Femi Oke. I am going to be your moderator for the next 1 hour and a half. Let me start with sharing some knowledge about interpretation. It will be in French, Spanish, and Portuguese. I know you know Zoom by now. I know you know exactly where to go, but just in case, there's a little globe at the bottom of the screen and on your dashboard. And on that globe, you will click on that and then you will find French, Spanish, or Portuguese, or English if you need that too. And that will be there for your knowledge so that you're able to understand and follow our conversation smoothly. So very close to the beginning of the COVID-19 pandemic, the WHO realized that there were going to be essential services for women who were giving birth, for children, for newborn, for adolescents that were going to be indirectly impacted by COVID-19. So what did? They put together an initiative, supported 19 countries initially with making sure that those essential services were not interrupted or trying to mitigate the impact of COVID-19. What we're doing today is what happened? How did it go? Lessons learned. How do we apply those lessons to future emergencies and crises as far as healthcare is concerned? This is what we're doing. We are reporting back to you, sharing the knowledge from the 19 countries, the different regions, country level, grassroots level as well. As this is a knowledge sharing event, you are part of it. You're not just receiving the knowledge. We would love your comments, your questions. There's a Q&A box. Put your comments and questions in the Q&A box anytime, and I will be wrapping them in to our conversation. All right, we have a lot to do. We have a lot to report on. Let us start with Dr. Anshu Banerjee. He's the director of MCA. Anshu, so good to see you. So much to talk about. Where should we start?
Thanks, Femi. And maybe we can go to the next slide. And just to say that the work that we undertook was really to maintain essential maternal, newborn, child and health services. And during the pandemic, this was really to support countries on how to do that. So we looked at how to prevent additional increases in mortality and morbidity, but also looking at malnutrition, mental health and physical ill health for women, children, adolescents and older people. And also at how we were looking at maintaining levels of service delivery as close as possible to those prior to the pandemic. And this was done in 19 countries in 5 WHO regions. You see the map there highlighting the number of countries by region. And we're very grateful to the support we had from the Bill and Melinda Gates Foundation for this. And our specific objectives were really looking at both supply and demand side issues. So on the supply side issue, our objective was to ensure continued access and coverage of essential services for maternal and newborn child health. And on the demand side was also to look at how to adopt strategies to prevent decreases in the utilization of essential services. Next. And the model that we used was really looking at 4 different areas. First of all, guidance that we provide, and WHO is known to provide guidelines. So we as a department also were involved in looking at how to adapt the guidance to maintain essential health services in this situation. But we also looked very much at information gathering and data, looking at real-time data use and looking also at pulse surveys, so asking stakeholders out in the field, what their opinion was about how its services were being utilized or not utilized. We also applied modeling and also looked at monitoring public health and social measures. The other area was, of course, really around the health service adaptations, around mitigating these actions. And so we looked at, for example, supply chain, at the delivery settings. So in what kind of situations were we looking at? Was it facility-based or was it remote provision of services through mobile clinics, for example? We looked also at how to improve communication and optimizing the workforce. And the last component was really around the governance. And this was mainly through technical working groups and how COVID was included in that governance model, or response to COVID was included in that governance model, as well as working together with partners. So the main things that we looked at was how to make sure that the technical working groups were part of the response structures at country level. And when it comes to data, really looking at how did we use routine health service information, and how did we compare that, for example, with previous years, to look at whether there were dips in service provision and how could we mitigate that. Over to you, Femi.
Thank you so much, Anshu. All right, let's start at the government level. I want to bring in Dr. Punya and also Dr. Roberta Paganini. Really nice to see you. Dr. Punya, will you tell everybody who you are and what you do, just briefly, before we get started?
You
can unmute yourself.
I'm Dr. Punya Paudel from Nepal. Now I am working in Family Welfare Division, MOHP, since 5 years. And I am section chief of maternal and newborn section. And I am obstetrician and gynecologist.
Fantastic. All right. And also you're about to hear a presentation from Dr. Roberta Paganini. Dr. Roberta, please introduce yourself very briefly to our audience.
Olá a todos, meu nome é Roberta Paganini, eu estou como secretária de saúde do município de Pelotas, município que fica na região sul do Brasil.
So good to have you. So, governance and leadership is what we're going to be looking at over the next 10 minutes. Experiences, challenges, lessons learned. When it comes to essential services, maintaining those essential services, it's government will, political will, that makes sure that that happens. Dr. Punya, we're looking forward to your presentation. Please go ahead.
Thank you, Femi. Good morning, good afternoon, good evening, and namaste to all the participants and organizers. Thank you very much for giving this opportunity to Nepal for sharing our experience in this webinar. I am sharing with you experience of Nepal in integrating MNCH priorities in emergency response and coordination mechanism. Next, please. During early 2020, when COVID cases were reported, the government of Nepal started preparation for responses. The COVID Crisis Management Committee, CCMC, was established, and this was chaired by Deputy Prime Minister, and the members of the committee were different ministries, including the Ministry of Health and Population. The incident command system and the health emergency operating center were also activated in this time. The health cluster was established during the 2015 earthquake emergency response under the leadership of the Ministry of Health and Population. And the health cluster was reactivated at this time. When few cases were reported in Nepal, the government imposed lockdown in order to help the women and children to access the essential RMNCH services. The ministry identified RMNCH's essential service and activated the reproductive health subcluster. And next, please. The reproductive health subcluster is led by the Family Welfare Division, consisting of members representing professional bodies, development partners, private sector working in MNCH area. And we defined the terms and reference of the subcluster, and we organized a weekly meeting initially. And when there was a complete lockdown time, Then the meeting were conducted fortnightly, and till now, September, we have already conducted 41 meetings till now. And the discussion in the meeting were extensively related to service continuation issues and immediate needs. And we coordinated vertically with health cluster, incident command system, and provincial and local bodies also. And also we coordinated horizontally with HMIs, logistic management, and training centers also. And there was a promotion of collaboration and partnership with partners supporting in the area, including WHO, to continue essential MNCH service up to the local levels. Next, please. Specific action taken to strengthen the governance and coordination for MNCH service during COVID-19. And these are the actions taken. These were MNCH services considered as an essential service, and collaboration between stakeholders to take policy and strategic decisions on MNCH services. And coordination with the local and provincial government as a decentralized government, and monitoring of MNCH indicators and supplies was done, and regular briefing in the health cluster and the incident command system was also done regularly. Outputs, I want to now talk about the outputs. Interim guidance developed for the continuation of essential RMNCH services at the time, and ensure that transportation availability of commodities and capacity building, dissemination of risk reduction, communication up to local levels. And at that time, a review of maternal death was also done, and action was also taken. And we also expanded digital health technologies at this pandemic time. Next. In terms of leadership, a key decision to continue maternal death surveillance and response MDSR during the pandemic, and coordinating at the national and provincial level, and the official guidance from Family Welfare Division to all the provincial and local bodies for notification and reporting of maternal deaths. And also Family Welfare Division modified MDSR tools to capture death from all sides, and mobilization of local municipalities and partners for reporting also done. And Family Welfare Division led regular analysis and discussion in RS subcluster, this process, and identification of causes of death and underlying health system factors leading cause was postpartum hemorrhage. And action also develop action plan, and also we include the management and prevention also. Next, please. And now lesson learned and challenges I want to tell about. And lesson learned was high priority for management of COVID-19 cases with diversion of frontline workers, and challenges in prioritizing MNCH services, challenges in mobility of service seekers. And at that time, inadequate supplies of PPEs for MNCH services in initial phase, and procurement of essential MNCH commodities, timely availability of service utilization data. Also, at that time, is a tablet of misoprostol was used shortage, and we have done procurement with the help of stakeholders also. And now I want to tell about lesson learned was identified the MNCH as essentials service during early responses from Ministry of Health and Population, and reactivation of RS subcluster was vital. And collaboration in a common platform RS subcluster was important for maintaining essential MNCH services to avoid the duplication and improve complementarity. Representation in the incident management team was important for obtaining resources for maintaining MNCH services and supplies. This is my short presentation. Thank you. Thank you so much.
Thank you so much. Dr. Paganini, it's nice to see you. We look forward to your presentation.
Hello everyone, once again I thank the opportunity. I will tell you a little about how the municipality of Pelotas faced the pandemic. As a tackling strategy, we seek to restructure the services in order to give continuity to more health services, prioritizing pregnant women, children, the elderly, and cancer patients. The coordination and response mechanism adopted was defined by a horizontal management model, which we call co-management, with the participation of several actors in society. It had a tackling committee coordinated by the municipal mayor, where there was the participation of several actors of the economy, such as the Association of Industry, Commerce, Construction, representatives of the Chamber of Councillors, universities, and hospital managers. In the Municipal Secretariat of Health, we work with two technical committees, one with hospital managers and the other with the universities. Pelotas is a municipality that has two rather important universities. In all these committees, we had the participation of the Municipal Health Council. The council represents the users of the unified health system of Brazil. So the Secretariat of Health started the co-management model in September 2019 because we believe that this horizontal management model, with the participation and appreciation of workers, service providers and users, add a diversity of important views to improve the services provided. Thus, it was possible to find solutions to the challenges imposed by the pandemic. For example, the creation of a COVID maternity, the monitoring and active search of patients who were suspected of being contaminated by COVID through telephone calls to pregnant women, children, elderly, and people with comorbidity who could have the risk increased. It should also be noted that one of the main strategies adopted was the assistance zoning, where we define which urgency and emergency entry doors would assist symptomatic patients, defining the hospitals that would be available for hospitalizations of these patients, and the primary care services, divided into two shifts. In the morning, we assisted symptomatic patients, and in the afternoon, other health demands, including care for pregnant women and children. It allowed the continuing of services, the care of COVID patients, and reduce the transmission in the health services themselves. Some actions were also important and worth highlighting, which was the surveillance for the return to school. We created protocols specific to the education sector through the technical reports elaborated through a joint work between sanitary surveillance, epidemiological surveillance, work health, Municipal Department for Education and Collective Health, and Maternal, Newborn, Child, and Youth Network, with the guidelines for prevention measures to reduce transmission and outbreak control protocols. In addition, we hold live and online meetings, all scheduled by the school health program to address various issues of interest to education workers. We also carried out training of the health network, technical reports regarding COVID for COVID prevention and reception with risk classification for symptomatic patients. Also, the work related to prenatal care and risk classification were also studied with primary care, agreement with hospitals when there was time to collect the neonatal health prick test already in the maternity hospital to avoid that this baby had to go to a basic health unit again. We kept all the vaccines as well. Another important action was the teleclinical care, a call center for COVID doctor's appointment, COVID care, psychological care for the entire population. Expansion of the program Better Early Childhood and Happy Child, where home visits were interrupted for a short period of the pandemic, but then we have already resumed, and we expanded the number of visitors, greatly expanded these teams, providing care coverage that went from about 170 families to more than 1,500. And another action that we consider also fundamental was the implementation of thematic care networks. As a consolidation of the horizontal managed model, the perception of the need for intersectoral care and healthcare networks as maintenance of the pandemic response coordination mechanism. In 2021, we created coordinations by care sectors, which we call thematic networks, which coordinate the flows and work process between the boards of the health secretariat, between service providers and other municipal secretariats, such as education and social services. Thematic networks are autonomous coordinations, such as the boards, and they are composed of servants of the Secretariat of Health from different positions, such as nurses, social workers, nutritionists, psychologists, depending on the network and action likeness. The decision to create these coordinations was due to the need to consolidate the networking between health services in a group that had a broad view of each line of care and not fragmented in the levels of complexity. For instance, the Maternal Newborn Child and Youth Network has a task, among others, to identify obstacles and possible improvements in work process between primary care services, specialized care, and hospital care, so as to provide a better service offer. And the board, each board looks at its services. Then the hospital board looks at the hospital issues, the primary care board looks at primary care issues, and the network looks at the whole. Another important service was an intersectoral secretariat between the Secretary of Health, Social Assistance, and Education, also to coordinate the implementation of intersectoral public policies. Considering challenges, we face human resources challenges, one of the main challenges. Professionals that are very overwhelmed, physically and emotionally worn out. Financial resources, the costs have increased a lot. And the resources that we have are the same, the revenues are the same. Another challenge was the implementation of telemedicine, finding ways for us to use telemedicine as an alternative, especially for the lack of specialized professionals. And another challenge is how to address the unmet need for expert appointments and examinations. There was already a very large repressed demand in this area, which increased a lot during the pandemic, so this is a big challenge that we have. And increased coverage of regular vaccines, non-COVID vaccines. The immunization coverage, the vaccine calendar, has been dropping every year, and we need to recover. As lessons learned, the horizontal management model, co-management, is the key ingredient. We understand that this horizontal model allowed us to find solutions so that we could keep the services working. Networked and cross-sectoral work is also a lesson we have learned. Training and continuing education in the production of technical materials are essential. This was very clear during the pandemic, and the qualification of multidisciplinary team. We have had very positive outcomes with these tackling actions. We were the last municipality in Brazil with more than 2,000 inhabitants that registered the first COVID death. We had only one maternal death this year, which was from COVID, but only one death all this year around. So we had many positive results, and we believe that the big key is this horizontal management model, the zoning adopted, the intersectoral work, and the training of the teams. Thank you very much.
Thank you so much, Roberta. And I'm going to bring in Dr. Anoma. Dr. Anoma, it's so good to have you. We've been looking at, from two different places, Brazil and also Nepal, a government level perspective on lessons learned in terms of delivery of maternal, newborn child services during a COVID pandemic. What comes to mind? How do you want to sum up this part of our conversation?
Yeah. Thank you, Femi, and then good morning and good afternoon and good evening where we are. So I'm really happy to share the lesson learned while implementing these mitigation strategies in the WHO Southeast Asia region. And then even though I couldn't understand as you, but I read the slides of Roberta. And actually, as we know that pandemic is a new experience for all of us. It's not a very good experience, but it's a new experience. And it's added enormous strains to the even well-developed health systems. And maintaining of essential health service was a challenge even at the beginning. But we have seen, yet some countries did better in maintaining maternal, newborn and child health and adolescent health services during this pandemic. Then from the regional experience, we found that the member states with the functioning advisory body, such as technical advisory group or technical working group, managed to mitigate service disruption through a better coordination and harmonization. And some countries have used this forum for even for the strategy development and also for the policy dialogue. So what happened actually during this period? During the pandemic, so this technical working group, either they were existing already in the country with their governance structure, or they initiated new ones, or they reactivated new one. So what is this technical advisory group? It's a magic word, no. This is a forum where all stakeholders meet in one place, and along with the RMNCH program managers at the Ministry of Health level. It's the forum that promoted evidence-based decision-making along with the partners. It's not the vertical that you do something in the ministry level or even UN level. It's that the forum discussed issues, reviewed data, and facilitated policy dialogue and decision-making related to the maintaining of RMNCH services. And the most important thing you have heard from some countries, that technical working group chair is participating in the incident management group, where they take the major decisions of managing the pandemics. So this linkage also extremely important. And also they do strong advocacy there. And also, I think you have heard this in the Nepal presentation very well, that how they have activated the RH subcluster. They have created during the earthquake, and then it was functioning, and then they reactivated it, and they have done enormous work on that. So this was, I think, one lesson learned. And other thing also, this initiative, even though it's very small, but it was very effective and efficient. And we have collaborative management response modality of 3 levels of organization work together. So WHO, you know that HQ is there, regional office is there, country office is there. So we have to work in hand in hand. And then how this initiative work is so that we strengthen the country offices. Country office is our face value. They are the people who work hand in hand with ministries of health as well as the other partners. So this modality, I think it's not very not very expensive modality. It's a very efficient, and then it works with a very catalytic funding. What we have done with actually, the project supported the country of strengthening of country office and the regional office to some extra hand with a very experienced person, and then they work through the RMNCH focal points in the country office, and they work very closely with the ministries and other partners. So this was, I think, the real lesson learned during this period. Even the initiative also promoted that. So when this mitigation initiative, so when you are creating the technical advisory group, that is the forum that you can discuss and take decisions. So I think this is again a lesson learned, and then we want to continue this even in our Southeast Asia region. We are continuing this even beyond even the this pandemic or mitigation of service disruption. So that continuing of these services as well as the broader RMNCH agenda. So that's what I thought that is the lesson learned from this. Thank you.
So, thank you, Dr. Noma, Dr. Roberta, Dr. Punya. Thank you so much. I have questions for our first panel. I'm going to save those questions towards the end. I'm going to move on because we want to look at 3 different countries and look at country examples. So we have Pakistan, Uganda, Romania as well. If you have questions for these presentations, they're very welcome. I see them all, I'm collecting them, and I'll also be weaving them into our conversation today, our knowledge sharing conversation. So where shall we start? Let's start in Pakistan. Dr. Sabine Afzal, please unmute yourself, make yourself visible, share your presentation.
Good morning, good afternoon, and good evening, everyone, depending upon the time zone you are. I'm Dr. Sabine. I'm working as a Deputy Director at the Ministry of Health in Pakistan. Next, please. COVID-19 first case was reported in Pakistan somewhere back in February 2020. And then as the disease etiology was evolving, we were not very sure how the disease was going about. So government took a little drastic action and we had a complete lockdown. As a result of complete lockdown, and if you look at these bars, the light purple ones are actually showing what was a pre-COVID stage, and then the COVID and the things start falling down as the COVID progresses in the country. And there was a marked decrease was noted in essential health services. I'm going to work more detail on how data was used. So you can see the antenatal services. I've just given few examples here. And there was also a decrease in immunization services. So next, please. So these findings, the routine data was used, the district health information system data was used, and certain specific actions were taken accordingly. These specific actions focused on zoning of the hospital, capacity building, SOP development, risk communication, and I'm going to focus on how the SOPs were developed. We already had a reproductive and maternal task force working in the country. We're working on various aspects of RMNCH and A services in the country. When the data shows decrease in utilization of the services, which we were looking and following over the trends, how the services were utilized, what were the trends. So these were then presented to National Control and Command Center, which is co-chaired by the Health and the Planning Minister, and has we have a very devolved health setup, has a representation from all the provinces, health department, as well as various line ministry that came together, the aviation, the port people, the other people, the hospital people, then experts from infectious disease, academia. So there was a whole NCOC, it was presented to them, and they referred and requested the subcommittee on RMNCH to develop SOPs specifically depending upon looking at the data. These SOPs were then developed and were endorsed by NCOC and were then uploaded on the website. And then there was increase, if you see in late 20s and early 21, the services start to improve. The utilization of the services for RMNCH start to improve. Next, please. But there are many challenges in the use of routine data. There are issues of governance and accountability. It is not normally used for decision making. There are HR issues. Either they are not present, the data entry operator are not, sometimes make error in the data. In the in the basic healthcare unit, in the periphery, in the primary healthcare, they are still using the manual system, the register to enter the data, and then the data analysis, collation. These are the issues. Then the infrastructure, presence of electricity, in IT connectivity, and then the quality and timeliness of the data. And then the data was only capturing the public health up to the district level. The tertiary care hospital, the big parastatal bodies like armed forces, railway, which has a very vast network of health services, is not captured by it, and definitely, and also the private sector. These are the interoperability with other data streams like lady health worker, which are community health worker, which are also reporting on RMNCH indicator, then community midwives who are also dealing with the RMNCH issues. Their data is not talking to the routine data. Next, please. There are many lessons learned. The routine data, despite of its challenges, and by improving its quality and timeliness, can be a key for decision making. And we can, from the COVID, we can use the routine data, and we can develop and introduce a culture of regular use of routine data for decision making, for policy decisions, and then taking them forward and implementation. At the same time, we need to equip our HR so that there is a proper entry of the data, then they can collate it, analyze it, and then can we use it. There should be a proper feedback to the from the province to the district about the data and its issues. And then we can always develop linkages, as for the COVID we did, where everybody, for the one government approach, where academia, other line ministry, private sector, everybody came together, and we are reporting on the COVID data, so that similar lessons can be learned, and using the routine data from these developing linkages with these various sectors which are not currently linked with it. Next, please. DHIS2 is one solution, a way forward to improve the quality and the type of data that we get from the routine data. Currently, there is no standardization of variables, and age and segregated is not received. But with DHIS2, these variables can be included. Pakistan has already piloted it in 2 provinces, Jhelum and Ukada in province of Punjab, 2 districts, and has now expanded it to 12 and intend to do it over the next year to the 36th district in Punjab. The rest of the country has also planned it, and they have learned the lesson, and it was presented to the all provinces, and the implementation plan has been approved, and they will also expand it to the country. Another issue that we are working on is interoperability with other data streams. We are working on, there's a data health hub has been developed at the federal level, wherein what IT people call enterprise bus will be created, where data streams can be different data streams without looking at touching their actual position. They can talk to each other, and then the data can be interoperable. Then use of telemedicine, especially areas in the periphery where they can link up with the tertiary care hospital or with a specialized hospital, and can take advice. And certain different pilots were done during the COVID, like Sehat Express, Sehat Kahani, where telemedicine was used for providing RMNCH services. Another area is to integrate MNCH indicator into emergency preparedness response plan to ensure that essential health services, especially the RMNCH services, are part of the overall emergency response. Next slide. I think this is my last slide. Thank you very much. And if any question, I'm happy to respond. Thank you.
Thank you, Sabine. We have questions, but I'm going to move on to the next presentation to save those questions for a little bit later. Dr. Simon Mohumuze, as you can see there, is ready. He's standing by, ready for his presentation. Let me just share something with you. There is a background document to this WHO initiative providing support to 19 countries initially to help them make sure that those essential maternal, newborn, child services stayed in place even though we were experiencing a pandemic. The background document is called Maintaining Services for Maternal, Newborn, Child and Adolescent Health During the COVID-19 Pandemic, Lessons Learned from Countries. And Simon was part of that document, part of that report. Simon, hello, welcome, good to see you. What do you want to share with us?
Thank you. Good evening, good morning, everyone. Allow me to share Uganda's experience in using routine data for maternal neonatal child health in terms of making decisions in the context of COVID-19. And I'm from the Makerere University School of Public Health, Uganda. As you may be aware, Uganda is the part of Africa. We have had two waves of the COVID-19. And unfortunately, our vaccine coverage is still low, less than 10%. And we've had considerable disruption in delivery and use of these services, particularly labor delivery and child health services being the most affected during this pandemic. Next slide. So we've been fully engaged in the use of routine data to make decisions. Data here in the country is analyzed on a bi-weekly and monthly basis to be able to make informed decisions at various levels. And this is mainly at the national level, at the subnational level, and health facility levels. And we see examples of disruption in DPT-3 vaccination for example, in April 2020, and this had to trigger actions. Next slide, please. Sorry. Yes, a drop in utilization of immunization services was detected early on in the epidemic. And before that, all outreach services had been suspended in a bid to mitigate the effects of COVID-19. Because of this drop, the outreaches again where the suspensions was uplifted, and currently we have national catch-up immunizations campaign to try and reach all the children that missed vaccination during the national lockdown. We also observed a drop in facility deliveries, as well as a drop in treatment of common childhood illnesses. And as a result, the government put in place several interventions, including transportation of pregnant women in labor, putting in place a voucher system to be able to transport women from hard to reach areas to be able to reach the facilities, but also the restrictions were lifted for women, particularly pregnant mothers, to be able to move during the national lockdown while everybody else stayed at home. All community outreach programs had been suspended during the first pandemic, but because of the drops that we observed in the data, these were resumed, particularly the integrated community case management of childhood illnesses, and the community health workers who are the custodians or who are the implementers of these programs were trained and equipped and given guidance on how to manage sick children during the pandemic while strictly observing the COVID-19 SOPs. Next slide. So just like the others have mentioned, we had a few challenges in using routine data to be able to make decisions. In the first place, concerted efforts were focused on reporting COVID-19 cases. That was in the initial phases of the pandemic, and not much on MNCH services. And so there was an issue in that focus was made to report COVID-19 cases, and the MNCH services were initially ignored. But later, as the data showed with the significant drops, now we had to focus again on collecting data on MNCH services, analyzing it, and being able to use it to inform decisions. The other challenge was non-reporting, complete reporting during the national lockdown. And this was largely because there was inadequate HR, the staffs were fearing COVID-19, there were transportation challenges, the health workers were being repurposed to provide COVID-19 relief, and so they were working in shifts. And so there was no commitment to be able to complete or fill all the reports as is required through the national health systems. Now, the other challenge that is worth mentioning was the use of virtual platforms, which is now the norm, especially for performance review meetings here back in the country. We still have remote areas that have poor internet access to poor internet, rather to internet connectivity. And so these areas missed out on this important opportunity of sharing data using this particular platform. Next slide. So a few lessons learned during this period.
It looks like we have lost Simon for the moment. Simon, I'm so sorry to interject. Luckily, we have his slide. Simon, keep trying to talk. We may have to just do that old-fashioned thing, that technological thing, which is turn it off and turn it back on again. We've just lost the connection, but just at the right moment. Lessons learned and conclusions. The pandemic highlighted the importance of monitoring essential health services in a more focused manner. And the pandemic provided unique opportunities to strengthen systems for generating quality data and making informed decisions. Simon, thank goodness your internet only let us down at the last moment. We have the slide. We thank you for your presentation. Now, I did mention that Simon was one of the authors of this background paper about the initiative to keep those maternal essential services going. It is not available yet, not yet published, but what I did put in the chat section was more about the initiative, the methodology, how it works. So you can keep looking at that space, that webpage, and it will give you much more information. So where have we been to so far in this section? Pakistan, Uganda, now we're stopping off in Romania. Dr. Matiscu, it's so nice to see you. Please share your thoughts and your presentation.
Hi, Femi. Hi, everyone. I am midwife Irina Matescu from Romania. I'm so happy to be here with you. And I will show you a little from our experience with pandemic times for mother, newborns, and children in Romania. I'm a midwife. I told you that already, assisting childbirth in private care here, and I until recently worked with the Ministry of Health in Romania. So what can we see here? We have data for severe disruption of hospital care. This is general care in Romania for children. So you see now we are facing wave 4. We also have poorly rate of vaccination. I think it's 35% right now. And still the hospitalization for children, it's not back to 2019. Maybe it doesn't need to, but we don't know that for sure. So you can see here is in April, the lockdown in Romania. And next slide, please. You can see in all types of care that we had the same problems. So it's mental health. I just selected something that is not possible to postpone. Mental health care for children and access for cancer care also for children. So you see severe disruption also in that two types of care for sick children. And also we have disruption in maternal care. If you can put me the next slide, please. We have a rise in maternal mortality in 2020. It's It doubled from since 2080, 2090, and now it's double in pandemic times. Here are 32 women that didn't need to die in our, okay, you can see the percentage, but the number is 32 women that died in Romania last year. So this is huge. We have also poor antenatal access to care. I saw other colleagues that face that also. So we have only 5% of women that were investigated in the first trimester for free public care in Romania in 2020. The other ones either go to private care or a huge percentage still no care at first trimester, and even some of them not until they gave birth. So no checkups for pregnancy for a lot of women in Romania. I put here, I put a slide with breastfeeding initiation in newborns, and you see C-section is very badly initiated because of the separation of the after surgical care in Romania puts the mother and the baby in different rooms, and you see it's a severe disruption in initiation for breastfeeding, more than 24 hours for more than 60% of children, and we have 60% C-section in Romania. This was also before COVID, the same as poor antenatal care, but now it's even higher. So maternal mortality, I told you that it is double now in Romania, and we have separation of mother and newborn. This increased. It was a problem, but now it's even worse. And separation for COVID positive mothers. I will be back in the next slide with that. Lack of access to good quality perinatal predates pandemic, and now it is exacerbated. It was exacerbated. And we have closure of ambulatory care at the lockdown, and the disruption of all non-emergency services, including antenatal routine services. And this was back, but very poorly, and also for public access, it's still very difficult to get good care for Romania pregnant women. Next slide, please. So what we did, what we can say that we learned from this telemedicine, of course, especially for primary healthcare, family doctors, general practitioners, mental health used telemedicine a lot. And of course, phone triage. This, as midwives, we did that well. But we are very few. We are only 500 midwives in Romania, so we need to be 12,000. So we helped, but at this number we helped just a little. And phone triage for pediatric care was done in several hospitals and several cities, so local initiatives in Romania, to avoid unnecessary hospitalization or unnecessary returning to hospital for neonatal care. So awareness among parents, prenatal education to, for example, symptoms of severe illness, cancer, pregnancy complication, because if they are informed and if they are educated, they will know if they need to come to hospital or not. Now, if a pregnant woman calls ambulance, she has to wait several days. So we are trying not to go to hospital if it's not really needed. Revision of the operational plan for health to include the introduction of the baby-friendly hospital initiative. This is something that in Romania is not working, so we looked at that problem that is before pandemic times, but now it got even worse. And also about midwifery care in communities, because in rural communities there is a lack of access to antenatal care, to neonatal care as well. So this includes technologies for antenatal care, for hospitals, and medical staff competencies for antenatal screening. Next slide, please. I will close in a little.
Okay.
can you put me the next slide? Thank you. So challenges, fear, of course, among the population, among the caretakers and decision makers. We have a challenge of having good quality real-time data, because it's not always available, unfortunately. And despite evidence and data, sometimes decisions continue to be based on fear or some different interests. Continuation of separation, mothers and newborns restricted or no access for birth partner during delivery, and unnecessary C-section. And I think the last slide, please. Can you go to next slide? Thank you. This is the last one, yes. Yeah, of course, fear is not a good advisor. This we should remember this. And real-time data is the key to understand the situation and take appropriate actions. And no matter what the situation, we need to have that health services for mothers and children. We cannot postpone that. So we now know that we have pre-existing weaknesses, and we need to build back better. Mm-hmm. Of course, country plan to include collection of data and timely use. And here, what I already told you, no matter what the situation, some health services need to be always provided. Thank you.
Thank you, Irina.
That's all for me.
We have so many questions, presenters, Irina, doctors. I am going to get you all to stand by. We are going to, in a moment, go to those questions. I want swift, efficient, excellent answers. The bar is set high for how well you're going to answer the questions. The presentations have been good. I think the Q&A section is going to be even better. But before we get there, Dr. Desta, so good to have you. Your reflections, your thoughts on what you've heard from the last three presenters. Please go ahead.
Thank you very much, Madam Moderator. Thank you all. Lessons from the past Ebola epidemic in West Africa has shown that there were more deaths from disruption of essential services than from the outbreak itself. Therefore, the WHO regional office has drawn lessons from the past epidemic and has made a policy decision to take a balanced approach to the COVID-19 emergency preparedness and response and continuity of essential services. As a result, the continuity of essential services has been integrated within the emergency preparedness and response plan, and programs from maternal, child health, and also NCDs are represented in the incident management team to work together as a team so that we ensure continuity of essential services, and guidance has been given also to countries to do the same. And it is actually a component within the emergency preparedness and response plan as Pillar 9. In the past, the monitoring has been focusing on emergency management with very little focus on continuity of essential services, especially for the vulnerable population. So, like I said, by drawing lessons from the past epidemic, now the monitoring and evaluation component of the emergency unit is including key indicators for continuity of essential services so that it will be collected at the same time and you have real-time kind of information on the status of continuity of essential services for mothers, newborns, children, adolescents, and even older people. So countries identified a core set of indicators for MNCH services for monthly monitoring. So they were reporting on monthly basis on those core indicators, and those data were collected, analyzed, and produced country dashboards to trigger decisions at national and subnational level. WHO has played an important role in promoting the use of data to monitor continuity of essential services. This was possible through availing the operational guidance and technical support to countries to facilitate the generation of quality data and support in-depth analysis, visualization of data, and use for decision-making at different levels. So in addition, the WHO initiative that we have been discussing so far has really provided additional opportunities to countries to strengthen the health information system in terms of human resource, analytic capacity, and also use of routine health information system. As a result, we can cite some specific actions taken by countries to improve the routine health information system. Like Cameroon has recruited more staff, whereby they have increased the number of facilities reporting on MNCH indicator data. Ethiopia has been piloting a public data visualization, which is an electronic dashboard at national level to monitor the continuity of essential services, now cascading to subnational level with WHO support. Uganda has really practiced regular and increased the culture of data analysis and sharing for decision-making with consequent improved decision-making. However, we still have some key challenges like Simon was mentioning. We have done a lot. We have improved in general the collection and use of routine health information data, but we still have issues with data quality. Routine data is a powerful means of monitoring continuity of essential services. However, data quality remains a huge challenge. We also have data gap. We don't have specific indicator data for specific populations in the area of adolescents, older people, and for some aspects of the area of newborn. The other challenge we have is data sharing. We have seen some reluctance or limited willingness to share data by some countries, which even when they have good quality data, this is a challenge which we need to address. The last and important challenge is really information and technology infrastructure. The COVID pandemic has opened huge opportunity for using the digital health platform or the digital platform. However, we have limited infrastructure in countries for real data monitoring and timely decision making. So what are really some of the next steps that we should concentrate? WHO should continue to provide support to countries on data quality improvement, analysis, interpretation, visualization, and use at national, subnational, and most importantly also at facility level where action is most needed. Governments and partners need to invest more in routine health information system so that they will have robust and real-time data for timely detection of health emergencies, as well as detection of changes in the delivery and utilization of essential health services by the vulnerable population. Countries and partners need to collaborate to invest in digital health so that we'll be able to automate and get real-time data for monitoring and decision-making. Lastly, Ministry of Health and partners should invest in documentation of best practices and lessons learned in order to promote learning across countries. Thank you very much. Back to you.
Thank you so much, Dr. Desta. Really good to see you. All right, we are taking a break from the slides. So let's take all the slides down. Presenters, Good job. Thank you so much. We have so many questions that we are going to go to the questions. Take the slides down. We're taking a pause for the slides. Slide manager. Remember the last slide we were on. Okay, just take it down. Take it down. All right. We have too many questions. We're going to go to the questions right now. We don't have too many. We have an amazing amount. Presenters, thank you. Great job. Let's put up the presenters so we can see them in the gallery. It feels like days ago, Robert asked a fantastic question. Robert, thank you so much for your patience. I'm going to go back to this, Robert and Dr. Punya. Dr. Punya, have a listen to Robert's question. Robert asked, which challenge did you meet to identify essential services that should continue and those that should be stopped or postponed? Robert, that is a fantastic question. How did you decide, Dr. Punya? Very briefly, go ahead. All right, let's take down the slide and let's see Dr. Punya. Dr. Punya, let's put Dr. Punya on full screen. Hello, Dr. Punya. From the very beginning of our program, Dr. Punya, are you with us? This question was from Robert. We're going into the Q&A now so that Robert's question can be answered and many others. Dr. Punya, please unmute yourself. Are you still with us? Is Dr. Punya still with us? All right, I'm assuming that she is not, so I will move on. If anybody sees Dr. Punya, do let me know. Let's move on with the question. Robert, sorry, that was a great question. Let me
She is there, Femi.
All right, Dr. Punya, I can't hear you. All right, how did you decide what the essential service that you were going to keep and the ones that you were not going to do in Nepal?
Which service were doing daily routinely? We thought that they are not essential for the maternal and newborn health. For the delivery services, we thought this is essential. Thank you.
Thank you. All right, so this question is from Lara. Lara wants to know what was done to strengthen WHO country officers. Anshul, as we just heard you there, pipe up, put your camera on so we can see you. What was done to strengthen WHO country officers? Lara wants to know that.
So we did support the country officers to recruit additional consultants to strengthen their workforce, who could then engage with the ministries of health.
Thank you so much. A question about telemedicine, and I'm going to bring in, let me just see, Dr. Sabine Afzal, stand by, make sure your microphone is on and your video is on. This question about telemedicine comes from Rosie. Rosie, thank you. Rosie wants to learn about the experience in using telemedicine beyond the pandemic and where the funding is coming from. Can you share that with us, Dr. Sabine Afzal?
Again, can you hear me now?
I hear you now. I hear you beautifully. Go ahead.
Okay. Pakistan piloted various telemedicine ventures in the country, but funding and sustainability is an issue because we do have the platform like IT infrastructure and things, but those are also required, especially in the remote areas. Currently, the president of Pakistan himself took notice of it, and he has requested to us for developing the budget. So we have submitted the budget to the president of Pakistan, and we are just waiting to how the government will eventually support us in doing this. And I think it's a very good question, because at the end of the day, sustainability and continued sustainability and funding does become a major issue for low and low middle income countries. Thank you.
Thank you. Great question. Thank you for the question. Dr. Betsy from the WHO AMRO Regional Office, could you please greet everybody?
Yes, good morning, everybody.
Hi, good morning. Roberta, hello. Nice to see you again. Come back into the conversation, Roberta. I'm going to ask you this question from one of our audience members. I know it's going to be interpreted, and then Betsy's going to come back and then give us the English version of what you said. Complicated, but doable. All right. Can we hear more, Roberta, about the qualification of disciplinary team from Brazil? How did this team support the mitigation efforts? Just briefly. There's a little gap because interpretation has to happen. Roberta, you with us? Okay, did you hear the question?
O que a doutora Betsy falou, além desse modelo horizontal de gestão que a gente já tinha, né, uma expertise, outra questão muito importante para o enfrentamento da pandemia foi o zoneamento dos serviços, foi o que nos permitiu manter todos os serviços funcionando. Então, definir quais eram os hospitais que faziam internação COVID para os outros que não fariam, para poder dar retaguarda às outras demandas, dividir os turnos na atenção primária também. Em relação à pergunta, são coordenações por linhas de cuidado. Então, atualmente, nós temos 7 redes temáticas, que é a rede da urgência e emergência, a rede materno-infanto-juvenil, a rede das equidades, a rede das doenças crônicas não transmissíveis, as doenças crônicas transmissíveis, a saúde mental, e cada linha, e a das doenças, da saúde mental, cada linha dessas de cuidado articula os serviços que existem no município e olha todos os processos de trabalho. Então, por exemplo, a rede materno-infanto-juvenil, ela olha desde como o pré-natal está sendo feito na atenção primária até os adoecimentos mais graves dessas gestantes, dessas crianças, né? Todo o acesso aos serviços e a qualidade do serviço prestado. E articula com outras redes, como também a rede materno-infanto-juvenil. Um aspecto que tem nos preocupado muito atualmente no município é toda a parte de saúde mental das crianças. Então, a rede materno-infanto-juvenil, junto com a rede de atenção psicossocial, tem articulado junto à educação, junto à assistência social, as próprias universidades, pensando da forma coletiva como a gente faz, que serviços nós podemos oferecer, qual é o fluxo para notificação de violência infantil, como é que faz o acesso aos serviços, de um cuidado coordenado não só da saúde, mas da saúde, da educação e da assistência social. Esse é um exemplo, por exemplo, né, dado para que vocês possam compreender melhor. Obrigada.
Thank you. Betsy.
Yes. Yeah, well, Roberta explained that they have these different groups, what they call thematic groups. They have they have, for example, one that is for maternal, child, and adolescent health, and they have any other several other groups in mental health, in chronic diseases, etc. Each of these groups have as an objective to improve the quality of services and to try to identify what are the barriers for the linking the different services, what are the barriers for improving, for having good quality of services. And the group is aiming to find what are the barriers and find solutions. But the group also connect to other groups. For example, the maternal and child health group may connect with the mental health group in order to better respond to mental health problems among children. And each of these groups is comprised by a wide range of different professionals. They may have nutritionists, social workers, doctors, nurses, etc. So that's the way, that is how they put this multidisciplinary approach into practice. Over.
Thank you. I noticed that some of the panelists are seeing the questions and typing answers to the questions. Thank you, panelists. Thank you, presenters. I really appreciate that. Irina is doing that. She's answering questions about her presentation in Romania. I really appreciate that. We have a question about telemedicine. Another question about telemedicine from Samia. Samia wants to know, how has it changed in other countries during the pandemic? How have other countries managed with the mushrooming of online consultation services? That is, in terms of regulation and maintenance, of quality services, so the mushrooming of telemedicine. Let me see, who shall I ask that to? Arena, have you seen that happening in Romania?
Yeah, for sure, it was a rise in using telemedicine, but we don't have a very systematic approach with that. So we don't have applications that are under surveillance. So every private provider has their own, or every public hospital, maybe they have some application for that, or if not, they are using WhatsApp or whatever we have for now.
Yeah.
But there is a direction with this, with European funding from resilience plan. So we have a lot of attention there for telemedicine in Romania, for transformation into a digital system for different types of care for patients.
Thank you. This question is from Dr. Testa. And he asks you, Simon, a question. Simon, are you still here? What strategies for maintaining services differ between the second wave of the COVID pandemic? Simon, you may remember it is in Uganda. Hi, Simon, are you joining us?
Yes, thank you.
Yeah.
I'm here. Sorry about the hiccup. We have had just
no
no
problems. Good. You're loud and clear. It was a dramatic end to your presentation. Thank you for allowing me to share it with the viewers. All right. So was strategies wave one, wave two, subsequent waves. What's the difference?
Yes. Actually, I would like to mention that the strategies have differed very, very much between the two waves of the pandemic. Initially, can give an example. Initially, in the first pandemic, all the community-based programs that would attract large masses or large gatherings were suspended. But because of the routine use of data, the data was able to show that most of the essential health services were being disrupted because many people access health services through community outreach programs.
Right.
And so because of that, there was a change, and almost all these suspended programs were reinstated. So community programs, again, were allowed to continue. And that also called for a change, a review and an update of the guidelines for coordination of essential health services, of which I was part. So we had to review the entire guidelines and put new guidance in place to allow these services to continue in strict observance of the COVID-19 SOPs. So there was quite a lot of change in strategy.
Thank you, Simon. I don't want to stretch your internet too much, so we just got that question in there and the response. Appreciate you. I'm going to put what we experience right now, this COVID pandemic, it's history. People will study in years to come. What did we do? How did we maintain essential services? What fell through the cracks? What incredible creative ways and workarounds that we came up with. I'm going to ask Dr. Lenka Benova to give us some historical context for emergencies, health crises like the one that we're in, what we've learned in the past. Lenka, over to you.
Thank you, Femi. Good morning, good afternoon, good evening. May I ask for the slides back, even though it's really nice to see everyone's faces on one screen. Bear with me for a couple of minutes. Thank you. Just as we were speaking over the past hour, actually, I've been slashing my own presentation because you've covered many of the points that I wanted to speak to. So thank you very much. My name is Lenka Benova, and I'm speaking to you from Antwerp in Belgium today. Next slide, please. And I was asked to share with you fresh findings from a report that is scheduled to be published next week, and I hope will be shared with you as will the other one on the 19 countries. It's a scoping review of interventions to maintain essential services for maternal, newborn, child, and adolescent health and older people, in which we included several disruptive events prior to COVID, and they include Ebola virus disease, natural disasters, humanitarian emergencies, and SARS. And we screened and searched through just about 30,000 papers to find 120 interventions, 65 of which were evaluated. And I will try to summarize very briefly some of the lessons and reflections from these events with you today. Next slide, please. I first wanted to briefly go through the 4 key problems that such disruptions cause in the provision and use of essential services. You will relate to all of these very intimately. They mean decreased provision of health services, the need to adapt services, especially face-to-face care when there is a danger of exposure. They include the decreased use of healthcare, such as we've heard about people not being able to get to health facilities or there is no transport. And they include increased need for care. So the disruption itself or lockdown or isolation create new needs among populations. And here I want to say something that is really quite unique about COVID compared to the other events is that it affected all the countries. And so the kinds of interventions we see historically where international NGOs or UN agencies or even other countries were coming to other countries to help following a tsunami or an earthquake are almost completely missing. And so everyone is tackling their own problems in a context that they know very well, and they're arriving at different interventions and adaptations, many of which, at least those described in the literature for COVID, are based on telemedicine, fully or partly. Next slide, please. So here I want to return to some of the disruptive events before COVID. And I think the experiences that we've heard from our colleagues from the 5 countries today concerning governance and concerning data use are exactly the kind of experiences and lessons that are missing from the literature from previous events. So this is an incredibly useful exercise to understand, you know, the richness, the details of the adaptations of the way that different health systems have handled these disruptions to essential services. And I just want to stop here and recognize just how much effort it took from people's time and communicating with each other and learning from each other during this exercise, during the time that everybody was incredibly busy already. So I think this is really fantastic, and thank you. I want to focus on 3 points from the previous disruptive events, bigger picture lessons on what seems to have worked. And I think when you look at maintaining essential health services, it's quite obvious to say that you need to add resources, not take them away, right? You need to put additional people to maternal and newborn child health because needs are also increasing. You need to additionally train or task shift or provide services in different places, such as mobile clinics, community health workers, organize a free bus service as was done, or remove user fees to increase the reducing demand, for example. And for the digital health interventions, for the telemedicine that we talked about, I think there are 3 critical resources. Those are people, including administrators, secretaries, IT people, legal frameworks which allow the use of telemedicine, and the existence of financial reimbursement for services provided virtually. The second point is interventions that maintain essential services view people as people rather than as doses of vaccines or prenatal visits. And I think this is something that we heard or read on Dr. Paganini's slides as well. When you look at individuals as whole people, families and the communities, or you ask people what they need, then you can much better target their needs, including nutritional, socioeconomic, and mental health needs. And the third point here is that the situation, the disruptive situation, is by nature dynamic. And so what we've heard from Irina, for example, is this key element: maternal and newborn child adolescent services cannot stop. It's a 24-hour, 24/7 shop. Otherwise, we are creating an irreversible damage, increasing the needs in the future. So the most informative interventions actually describe not one intervention, a static intervention, but a continuous sequence or cascade of adaptations. So for example, during SARS, when services had to be closed in one of the Toronto hospitals, those clinicians describe how they coordinated with all the other hospitals in the Toronto area to be able to continue providing care. And I think I had a point on learning, but Femi, may I turn this back over to you because we're running up against time, and I know Dr. Anshu wanted to make a concluding point.
Except that, Lenka, everyone's going to go, what's that point about learning? I will never know. Will you just make it? Can you make it briefly, even if you don't click through the slide? Is that possible?
Yes. I have those 2 points. You see a scaffolding and a signal.
Yeah.
I think that's my 2 challenges to all of us. How do we create a scaffolding for learning the lessons, not just accumulating and documenting the lessons, but actually incorporating those lessons and that learning into what we do in the future? How do we share, including how do we publish, how do we write, where do we put all these adaptations so that others can learn from it within our countries and across the globe? And the second one is a challenge on signals. So we heard from Uganda, you know, they're analyzing their routine data bi-weekly. That's not enough sometimes in an emergency. How can we structure a network of signals where we hear within the health system, we learn from within the health system, what is going wrong immediately? What are the bottlenecks, even if those signals might not be formal structures at the moment?
Okay, thank you so much. We go from Lenka's global lessons learned to next steps. Dr. Anshu Banerjee is back. He started us off in our conversation, our presentation, our knowledge sharing event. Dr. Anshu Banerjee, this is the perfect question for you. Uden asks, next steps for strengthening services. This should be part, this is the thing that that they're really interested in learning about. So, bearing in mind, we are closing up this event. What would the next steps be, Anshu?
Thanks, Femi. And I think it's very important that we recognize what we have learned from these 19 countries. I think, first of all, a very clear message from the different country examples that we need to integrate the mitigation of services for essential health services, whether it's maternal, newborn, child and adolescent health, or some of the other ones as well, whether it's TB, HIV, malaria, etc., into the management structure for the emergency response. So that's something that we need to keep in mind. And as we go into preparedness planning for future possible events, we need to make sure that that's part of it. Secondly, I think the component on data that Lenka also highlighted, what we really learned from the countries was the immediate response to look at how to compare routine data that came in during the pandemic with the year before to see what's going wrong, where are we going wrong, and how can we respond to that? And as well, the national level modeling that was done in a few countries to sort of say, what would we anticipate and what is actually happening based on our routine data, and how do we adjust our policies and our interventions to take that forward? So another very important lesson. And thirdly, I think on the learning, as Lenka closed there, very important that we don't lose the lessons learned that we have collected, let's say, over the last years. What we have seen in the past is that we learn lessons, but we don't apply them afterwards. We don't apply them in the recovery. And I think now has come a time where we need to really make sure that the lessons that we have learned are documented, are evaluated, and are taken into consideration in our recovery, in future preparedness planning. And that another thing that we have seen in Brazil was the example of that, is that it's not only at the national level, it's also at the municipality level or local level. And people at local level make their own decisions. As Lenka highlighted, they are in their own system, they understand what's happening, and they respond to that. And we need to learn from that and evaluate those lessons to see how we can include them in future service delivery and planning. Thank you.
Thank you very much, Dr. Anshu Banerjee. Thank you to all of the presenters, all of the panelists, all of the discussants for your excellent questions. So many, can even squeeze them all into the Q&A section. But I know that you will be following online the WHO Maternal, Newborn, Child and Adolescent Health and Ageing Department. They will be bringing you background papers, more information, sharing their initiatives with you. But for now, we thank you so much for joining us for an hour and a half of your day today. Take care, everybody.